Hi, I am Smitha Sadasivan from the Civil Society Engagement Mechanism for UHC 2030 and a person with multiple sclerosis from India, also part of different networks of persons with disabilities and patient advocacy groups in India. The zero drafts of the political declaration for universal health coverage and pandemic prevention preparedness and response are acknowledging the fact that women, persons with disabilities, and older people, among other vulnerable groups, lack quality health services and need more focus towards ensuring their health equity. The inclusive approach towards these vulnerable groups in the discussions and drafts for both the political declarations is a welcome approach. There are also concrete points on financing as well as monitoring and accountability at the country, regional, and global levels, which is much appreciated. Yet, myself, being a woman with a rare disease and disability, living with aged parents, and working from community based collectives at the grassroots levels, as well as being part of discussions at the global level, I see a lot of scope for improvement in the context of inclusion and intersectional focus with regard to gender, persons with disabilities, and the older population. There are excellent instruments, documents, strategies, tools, and reports on inclusion of different vulnerable groups by the UN agencies and other international actors, which also seem to result more often in compartmentalized actions rather than holistic inclusion of all. This is also evident with in-country policies and programs where the Women and Child Welfare Department doesn't cater to the essential needs of women with disabilities or elderly women, and health policies being non-inclusive of disability-related health services, assistive technology, or SRHR services for women with disabilities. For instance, weekly infusions of people with multiple sclerosis is neither affordable by people from low resource settings nor is it user friendly under the government NGO collaboration, which takes 2 to 3 days of hospitalization instead of half a day's administration. This is a big hassle for people traveling from districts or villages to the general hospital in state headquarters, as the service is not available with local PHCs. Because of this, the accompanying family members lose out on their jobs regularly for half a week. Moreover, traveling again after 3 days for next weekly infusion really increases the fatigue and trauma. Inaccessible infrastructure at local healthcare centers is another critical issue faced by persons with disabilities and the elderly. Regular health accessories like diapers, catheters, bedsore cushions, even wheelchair cushions, or even portable oxygen cylinders and maintenance of assistive devices lead to huge expense on a regular basis, which are not currently covered under UHC. Despite monitoring and support by NGOs, many persons with disabilities and chronic health conditions continue to die on account of bed sores. This also indicates that the lack of person-centered care or personalized health attendance is a huge issue for many people with disabilities needing high support and the elderly. It adds to the day-to-day struggles of the families from lower socio-economic strata because it is the family members who obviously take the role of caregivers despite being the breadwinners of the family, and mostly they are women. The scenario worsens when health emergencies or humanitarian emergencies occur. During the pandemic lockdown, a fellow lady with multiple sclerosis who is a wheelchair user and lives alone could not access her day-to-day food as her known attendant could not reach her due to lockdown. There are a lot of cultural and social restrictions a woman with disability faces while seeking support in comparison to a man with disability. Similarly, many persons with disabilities, especially women and the elderly, could not access their regular medicines, health accessories like catheters, maintenance support for assistive aids, mental health and SRHR services, or even get any other emergency medical support in local hospitals, nor the COVID care centers were accessible. Another yet ignored fact, as mentioned before, is that it is mostly the women who take the roles of community health workers as well as health attendants to persons with disabilities and elderly, or be the caregivers to their own family members. The trauma and health hazards they undergo during the care they provide without breaks is a huge concern which needs specific health and rehabilitation services and targeted wellness interventions. In addition, the huge knowledge and expertise of these women, who tend to be the community health workers at the grassroots, is not given any attention or importance. This needs to be addressed for the holistic well-being of the society at large. There is a definite need for holistic and comprehensive healthcare that is inclusive of multiple options for disease-modifying therapies, rehabilitation, and assistive technology, essential health services, and nutritional food supplements specific to one's health condition, gender, disability, or old age, person-centered care as well as palliative care, maintenance support for assistive aids and technology, accessible SRHR, mental health, and WASH provisions, inclusion of screening and diagnosis, person-centered care, and accessible health information within universal health coverage is a must for holistic health care of all vulnerable groups. Health equity cannot be established when general health services are not planned to reach vulnerable groups such as women, persons with disabilities, and elderly. The twin track approach of the Convention on the Rights of Persons with Disabilities to include persons with disabilities, that is the vulnerable communities, in all general health services and systems, as well as ensuring focused programs for their specific health needs, can only be the way forward. Not to forget to include them at all levels of policy discussions, from R&D, data, planning, training, and implementation. In India, currently our health ministry decided to drop the disability questions from National Family Health Survey 6, which is the key data for tracking SDG progress in country. The entire disability movement is advocating for the inclusion of disability data right now. In this context, wherever the zero draft talks about policies, services, well-being, decisions, data, research, financing, monitoring, and accountability, clauses should be added to ensure effective inclusion of these vulnerable communities in the process as well, and not just the reach. There should be checks and balances of intersectional care and services among vulnerable groups, despite the mention of specific international instruments like the Beijing Platform for Action, CRPD, and the WHO technical briefings on disability, healthy aging, mental health, NCDs, etc. Within the zero drafts. It is imperative that women, persons with disabilities, and the elderly from the community get a seat on the table when health discussions are held at all levels, as well as in the due process of execution and monitoring. To facilitate these objectives, UHC 2030 came up with the UHC 2030 Action Agenda, which could be further advocated with member states to strengthen the zero drafts of both the political declarations. The motto of CRPD, nothing about us without us, when realized effectively, can ultimately result in no one being left behind in the holistic health and wellness agenda. Thank you very much.